Hello, everyone. So I am going to lecture this week about anxiety disorders, but before I do so, I really wanted to just talk with all of you around discernment and curiosity when you are working with an individual who may need a diagnosis, so that you really aren't looking at the individual as, this checklist of symptoms that you need to go through. So for your one of your discussion posts this past week, you were asked to diagnose Elizabeth. So I just wanted to comb through this vignette with a bit of a critical eye, not meaning judgmental, but really looking through some of the contextual factors. So my hope at the end of this is not that you get the message to not diagnose or anything, but I really wanted to go through this little vignette, which, as we know, these are limited in their ability to really give us kind of the depth and complexity of our potential clients or our potential patients. This really is a practice in diagnosis and looking at somebody through a diagnostic lens. I also want to encourage you to look at this individual through a humanistic lens, through a culturally informed lens, through a feminist lens. So I'm just going to look at some things that I think can easily be looked over, that I just want to give you the opportunity to take a second to pause and think about some of these aspects. So we're looking at Elizabeth. She has come into our office with her husband. Elizabeth is Persian. I don't believe we know anything geographically really about her second husband, Donald. So Elizabeth is 38. She has two grown children, and then she and Donald have an unplanned pregnancy. So here you see this unplanned pregnancy, which, quote, upset her, but they decided to have the baby. So some questions I would think about are, what was it about the pregnancy that was upsetting? How did they come to decide to, take the pregnancy to full term and to birth a child? So I'm just, is it that Donald said, Elizabeth, if you don't have this child, I don't believe in abortion, I will not participate in that if you do not carry this pregnancy to term and have my baby, then we will get a divorce. Was Elizabeth raised in a, kind of anti-choice, pro-life, however you want to term it, where abortion just wasn't an option, adoption wasn't an option? And so Elizabeth is feeling incredibly stuck here. Since the news of the pregnancy, she's seemed unnaturally sad. So she was upset about it. To me, the unnatural, I quite frankly don't know what unnatural means. So I would be wanting to understand a little bit more about that label. That she's sad, which to me makes sense. She is likely, but again, you have to ask, feeling stuck about this pregnancy, maybe feeling that she doesn't have any agency, she doesn't have any choice around this. So for 4 months, she spent a lot of days in bed. She wasn't arising until afternoon. And then she would be less tired. Her appetite was ferocious in her first trimester, but that fell off. So again, her ferocious appetite in her first trimester, which, as we know, very well may be because she's pregnant. So that by the time of delivery, she was several pounds lighter than usual for a full-term pregnancy. So again, these are just descriptors. What does this mean? Is Elizabeth a smaller framed person? as we know, for example, things like the BMI, they're very flawed in the way that we kind of try to normalize, meaning like putting everybody on the same scale, not normalize in the sense of therapeutic normalization. But so that being several pounds lighter than a full-term pregnancy, to me, that is like quite valued. That may be very irrelevant for Elizabeth. So it would be interesting to know what was her like kind of weight gain during pregnancy in her first two pregnancies. What was her mother's and her grandmother's pregnancies like? So these are all, things that you don't take at surface level to go, oh, several pounds lighter, check, move on to the next thing, ask questions about this. She had to give up keeping the household and business accounts because she couldn't focus her attention long enough to add a column of figures. I would really, really investigate this portion right here. So this is giving a very linear, causal explanation for the keeping of the books and the keeping of the household. As systemic thinkers, we don't think like that. So I'm curious, like, what kind of value did Elizabeth get from keeping the household and business accounts? Was that her form of contribution to the household, that she no longer was able to perform at the same level? That created quite a bit of distress in her. So really asking her, tell me about the keeping of the household and the business accounts. What did that mean to you? What did that provide you? What was that like for you to no longer be able to do that to the standard of what you thought before? Or she couldn't hold attention long enough to add a column of figures. Like, whose voice is this? Is this Donald? Is this Elizabeth? Who is expressing that this is the reason why she's no longer in those roles? So the only time Donald became really alarmed was one evening in the beginning of Elizabeth's 9 months, when she told him she had been thinking for days that she wouldn't survive childbirth and he would have to rear the baby without her. So one of the things that also comes to mind here is that fatality in childbirth isn't irrational to me, particularly being a Persian woman, a woman of color, where the statistics are not in her favor. Also, I'm also thinking of the fact that she is 38. So I would be very unsurprised if the term geriatric didn't come up multiple times in any of her doctor's appointments, of how she's at, quote, high risk because her pregnancy is geriatric. So I'm just thinking about, so again, investigating some of the messages around this. So you'll both be better off without me anyway. So this is a very isolated comment, right? We're literally just getting this piece of information, dive into it, understand it a little bit better. What was going on? Did they just have a fight? Was Elizabeth, what was her state of mind? She's 9 months pregnant, having gone through this for a third time, an unwanted time. Where was she at with all of that? Where was she at with her children? Where was she at with Donald, her family of origin, all of these things? What were some of the relational dynamics? Get a fuller picture of the individual. So after their son was born, her mood brightened, the crying spells and the ruminations disappeared. And she seemed almost her normal self. What does this mean? That's what I would wonder. Donald returned from catering a banquet to find her in her bra and panties, icing a cake. And the 2 other Just Ice cakes were lined up on the counter, and the kitchen was littered with dirty pots and pans. So again, is this Elizabeth's duty? Is this agreed upon that she's the one who is cleaning? So it's set up here that she was no longer able to keep the household. So is this now Donald's contribution to the household? Did they talk about this? This is all also Donald's account too. So she said she'd made one for us and she wanted to party. He told the clinician, I started to change the baby. He was howling in the basket, but she wanted to drag me to the bedroom. She said, please, sweetie, it's been a long time. I tried to shake her off without hurting her feelings so I could help the baby. I mean, even if I hadn't been dead tired, who could concentrate on having sex when the baby crying like that? I felt very confused. So again, this is important, right? So this is some collateral information that you're getting from Donald, but still really interested in Elizabeth's perspective here. So she spent nearly $300 for Christmas presents at an April garage sale. So again, is this abnormal? What is Elizabeth and Donald's, what is their SES? What is their financial situation? Is this something that is really out of the ordinary? Is this something that would financially be a burden to them? She decided to open a bakery, charge $1,600 worth of kitchen supplies. So we know that these are some potential symptoms that would meet criteria for bipolar. We're not sure, or at least like a manic or hypomanic episode, I guess I should say. So Elizabeth's behavior became so erratic that for the next 2 evenings, Donald took off work to care for the baby, but his presence only seemed to provoke her sexual demands. So again, we're looking at timeline here with any sort of meeting of symptom criteria. I'm also, this I am becoming a god, I think on the surface could very much look like a hallucination or a delusion. But I'm also curious around like any sort of like cultural, and again, remember, cultural is not just ethnicity, it's not just country of origin. It's not just a regional area, geographical area. I would be curious around, any beliefs about childbirth. And I mean, you could argue that creating a human and giving life to a human, that is what, at least in, Christian Bibles or Christian theology, that is what God does. So I really just wanted to walk you through critical ways to look at the vignettes that aren't just, oh, okay, well, she was sad, that's a major depressive disorder, check. Oh, she thought she was becoming a god, that's a delusion, check. Humans aren't checklists. So please try to look at these through a really thoughtful, purposeful lens that is critical of any of the criteria coming forward. The thought first is normality. So, discern, does this make sense? Also, it may make sense, but it may also meet criteria. So just simulating, engaging in a conversation with your client, with your patient, with any informants, so that you're not just going through and like not seeing the humanity in the person. So I really want you to incorporate, some of these thought processes as you are writing in your discussions, as you are writing about these, to go through and say, I was wondering about Elizabeth being, literally typing, I was wondering about Elizabeth being 38 and what kind of messages she may be getting from her OBGYNs around her pregnancy. I really was curious about how she and Donald came to the decision to have the baby. Was it coercive? Was it thoughtful? Was it agreed upon? How did Elizabeth feel about coming to the decision? So I encourage you writing all of that. That is part of the process. It's not just about slapping a code on a treatment plan or on a progress note. It's about seeing the humanity and the symptoms that are presenting to into the office with you. So if you have any questions or anything like that, please don't hesitate to come to mine or Ivy's office hours to shoot us an email. But I cannot stress to you enough that humans aren't checklists. Okay, so from that vignette into our lecture for this week. So this week we are covering anxiety disorders. So this grouping of disorders, they are made up of features of excessive fear and anxiety and related behavioral disturbances that we'll discuss. Fear is the emotional response to real or perceived, or a perceived imminent threat, whereas anxiety is anticipation of a future threat. So you can see that fear and anxiety are differentiated here. Fear is something that is kind of current, and anxiety is anticipated, something that may happen. And so emotions are evoked from that. But with the group of anxiety disorders, each of them differ from one another on the types of objects or situations that induce the fear, anxiety, or avoidance behavior and the associated cognitive ideation. So that's how you differentiate each one of these anxiety disorders. So the first that we'll be covering is separation anxiety disorder. So this is a pediatric diagnosis that can be apparent or present in adulthood. It is more common in children. So this is developmentally inappropriate and excessive anxiety concerning separation from either home, which that is more common in adults, or major attachment figures, which is more common in children. So if you go through those 8 criteria in the DSM for criteria A, the individual needs to meet 3 of those 8. And then in terms of a timeline or a period of time, duration of symptoms, that it must last for a period of at least 4 weeks in children and adolescents younger than 18, and then 6 months or longer in adults. So another criteria for here, a descriptor, is that it must cause clinically significant distress or impairment in social, academic, or occupational functioning. So remember, clinically significant is really determined by you and the client. So you, of course, are bringing in some of your, expertise, your professionalism into this, but you also have to get an account from the client of how this anxiety, how this distress is affecting them in the areas of social, academic, occupational, or any other important areas of functioning. So you're going through each of those portions of their life or aspects of their life and looking at how their anxiety, how their distress is affecting each one of those areas. So for children, when they are separated from a major attachment figure, so again, this doesn't necessarily have to be, like a biological parent, though those are parents or caregivers are generally the attachment figures that we talk about, but you really want to understand who this person is to the child, and who are the primary caretakers or caregivers of the child. So when they are separated from this individual or individuals, they may exhibit social withdrawal. So they're not, engaging in a setting that normally or commonly the child would participate. They may have some apathy, some sadness, or difficulty concentrating on work or play. So just kind of a general, checking out of situations. So separation anxiety disorder decreases in prevalence from childhood through adolescence and adulthood, and is most prevalent. It is the most prevalent anxiety disorder in children under the age of 12. Separation anxiety disorder, I think very logically can follow a major life stressor or a loss. So death of a relative or a beloved pet, an illness of an individual or relative, change in schools, a divorce, a move to a new neighborhood, a move to a new country, a disaster that involved periods of separation from attachment figures. This might be something like a natural disaster, where there was a hurricane, an earthquake, a fire, something that happened where the child wasn't able to be in the presence of these, people who really offer the child comfort and support. There also is a genetic component to separation anxiety. So it is heritable in 73% of like this sample of 6-year-old twins. And girls tend to have a higher rate than boys in this. So if there's a history of separation anxiety diagnoses in a family, it is likely that future generations will also be diagnosed with that. Another generally pediatric diagnosis is selective mutism. So this is when there is a consistent failure to speak in social situations where there's an expectation to speak. And that these are specific situations where a person may not speak when they do speak in other situations. So for example, children with selective mutism, they may speak at home in the presence of immediate family members, people that they are close to, but then they may go with extended family that they're not as familiar with, not as close to, and not speak. And so selective mutism is usually marked by high social anxiety. That's a diagnosis that we'll get to in a little bit. So some features, so again, something that you're looking for within the individuals that you are working with: excessive shyness. So again, all remember, like a term like excessive, what does that mean? How do we measure it? Always looking at the criteria and how it makes sense in context, or how do you define it in context? Fear of social embarrassment, social isolation and withdrawal, clinging, compulsive traits, negativism, temper tantrums, mild oppositional behavior. So these are all things that could be present with a diagnosis or with the criteria or the exhibiting of selective mutism. So selective mutism usually occurs before 5 years old, but the disturbance may not become like to clinical attention until the child goes to school. So when they're in another setting, so maybe it's there, but they're never in a setting that brings about the exhibiting of selective mutism. So when there is an increase in social interaction or tasks that they have to perform, that's where it may become more apparent, because again, they're in social situations where the expectation is for them to talk, but they are not. So then there is specific phobia. So pulling from our essentials textbook, the screening question here would be, do you have a particular fear that causes you special trouble, like flying, heights, closed places, animals, seeing blood, or getting an injection? So this specific phobia is characterized by marked fear about a specific object or situation. That these objects or situations are called the phobic stimulus, or potentially phobic stimuli if there are multiple. It is common for individuals to have multiple specific phobias. So the average individual with a specific phobia fears 3 objects or situations, and then 75% of individuals with a specific phobia fear more than one situation or object. Code each of them. So you see in the DSM that each of the specific phobias have a code. Put them all in there. So again, comes with a conversation with the client or with the patient. So when we talk about active avoidance, what active avoidance means is that the individual intentionally behaves in ways that are designed to prevent or minimize contact with that object or with that situation. So if, for example, they are afraid of tunnels, they will take a completely different route home. So let's say they have to go under a bridge on the shortest route from home to work. They will take a longer route. They will add substantial time to a daily commute in order to avoid going under that bridge or over that bridge, through that tunnel. They will avoid entering a dark room for fear of spiders. They will avoid taking a job where a phobic stimulus may be. So it's, it would be in the way of potentially negatively affecting their financial situation, their employment. It would cause, or it would be a contributor to, substantial inconveniences potentially in this person's life, again, in terms of time, interactions, stuff like that. So like separation anxiety, a specific phobia can sometimes develop following a traumatic event, observing others going through a traumatic event, an unexpected panic attack that happened in a certain situation. So for example, if they have this panic attack on the subway, they may then develop a phobia of being in the subway. That may also be through informational transmission. So a lot of media coverage over a disaster that has happened. However, many individuals with a specific phobia really don't know the origins or can't really offer an explanation. So that doesn't mean that it's any less valid. It's just that some people can say, oh yeah, I know exactly how I came to fear airplanes. This is what happened. Or I have no idea how I've ever come to fear airplanes. I used to be fine on them. Now I am not, or I have never been fine with them, something like that. So specific phobias usually do develop in early childhood, with the majority of cases developing prior to the age of 10. So again, we know that there's lots of variation in this. The DSM just offers you with some, statistical information on prevalence. So when being diagnosed in children, 2 issues that you need to consider. So young children may express their fear of anxiety by crying, tantrums, freezing, or clinging. So again, they may not be able to articulate in the way that an adult could. And then typically children are not able to understand the concept of avoidance. So you should be able to assemble additional information from parents, teachers, or others who know the child well. So these are those informant interviews where you are just maybe working with somebody who's unable to, again, explain. The concept of avoidance can be quite abstract. Children aren't abstract thinkers yet. So taking all of those developmental pieces into consideration as well. So social anxiety disorder or social phobia, the screening question here could be, do you frequently avoid social situations because you are afraid of doing something stupid or looking silly? So with social anxiety, it is characterized by marked fear or anxiety. So again, current or anticipated, emotions about a social situation in which the individual is exposed to possible scrutiny by others. So in children, the fear or anxiety must occur in peer settings and not just during interactions with adults. And then in social situations, they must almost always provoke fear or anxiety. So if an individual becomes anxious only in certain situations, they wouldn't be diagnosed with social anxiety disorder. They may be meeting criteria for a specific phobia, though, just so keeping that in mind. Individuals with social anxiety disorder often overestimate the negative consequences of social situations, and thus their judgment is out of proportion. So the judgment of this overestimation, or the judgment of these consequences and social situations being out of proportion with one another, that's our call as the clinician. So again, you want to gather as much information as possible about this, because your presumptions, your biases, your preconceived notions, those are all going to affect your judgment. That's not a bad thing. That's just a real thing. So the more information you can gather, the more accurate your clinical assessment can be. So naturally, the individual sociocultural context needs to be taken into account. So again, this is not just ethnicity. Issues of diversity are every aspect of a person's social position, every aspect of a person's identity. So this is gender, race, ethnicity, religion, ability, sexual orientation. Did I say gender identity? I think I may have. Immigration status, relationship status. The list is so long. And these are all important areas to consider. So a 6-month duration threshold helps to distinguish the disorder from a transient social fear. So remember that the 6-month duration is meant to be flexible, but it is meant to just kind of give some kind of anchoring to be able to diagnose this in a meaningful way. And then individuals with social anxiety disorder may be inadequately assertive or excessively submissive, or less commonly highly controlling of the conversation. So these are other manifestations, but again, inadequately assertive, according to who, according to what, excessively submissive, according to who, according to what, measured how. Individuals may show overly rigid body posture. Again, overly rigid body posture. What does that mean? Inadequate eye contact. What does that mean? That is incredibly culturally bound as well. Or speak in an overly soft voice. What does that mean? So again, when you are seeing any of these valued terms, be aware that these are very culturally bound. These can be very situationally specific. They are very contextually and culturally specific. So just be aware when you see words like this and definitions and descriptions in the DSM like this. Median age of onset in the US is 13. 75% of individuals have an age at onset between 8 and 15 for social anxiety. So again, there's a genetic component to this, that first degree relative. So these are individuals who share at least 25% of their DNA with these individuals, have a 2 to 6 times greater chance of having social anxiety disorder. And the liability to the disorder involves the interplay of disorder specific and non-specific genetic factors. So then panic disorder, the screening question here would start with, have you ever had a panic attack? So panic disorder is characterized by recurrent, unexpected panic attacks followed by a month of worry or a change in behavior related to the attacks. So just know that panic attacks can be both expected or unexpected, but the criteria for panic disorder are unexpected panic attacks. So a panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4 or more of the list of 13 physical and cognitive symptoms occur. So going into that, the criterion for panic disorder, looking at that list of 13, does the individual meet criteria for 4 or more of that? So then panic attacks are differentiated by expected or unexpected. So expected generally means that there's a clear trigger. Something happened, makes sense. This panic attack, again, put in context, could be kind of anticipated or predicted. Then unexpected, there's no clear trigger, or it's considered out of the blue, which doesn't necessarily make the panic attack any more or less distressing. These are just 2 different kind of precedents to it. And then the median age of onset is between 20 and 24, and most individuals report identifiable stressors in the month before their first panic attack. So these are things like interpersonal stressors, stressors related to their physical well-being, like a negative experience with an illicit or prescription drug, a disease, or a death in the family. So many times the first panic attack, when somebody looks at that retrospectively, they can see maybe some reasons or some life stressors that were happening that maybe the body reacted to a little bit later. So panic attack specifier, So the essential feature of a panic attack is, like I said, an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, during which time 4 or more of the 13 physical or cognitive symptoms occur. So the term within minutes means that the time to peak intensity is literally only a few minutes. So I would say 5 or fewer minutes. A panic attack is distinguished from ongoing anxiety because its time to peak intensity occurs within minutes and its discrete nature, and then it's typically greater severity. So a panic attack has greater severity than ongoing anxiety. The attacks that meet all criteria but have fewer than 4 physical or cognitive symptoms are referred to as limited symptom attacks. So they still have, again, some weight to it. There is validity to it. They are just called something different. So for that panic attack specifier, the determination of whether panic attacks are expected or unexpected is made by you. Who makes this judgment based on the combination of, again, careful questioning as to the sequence of events preceding or leading up to the attack, and the individual's own judgment of whether or not the attack seemed to occur for no apparent reason. So you're not making this you're not distinguishing on your own. This is a conversation that you are having with the client to like kind of come up with that label of expected or unexpected. Physiological recordings of naturally occurring panic attacks in individuals with panic disorder indicate abrupt surges of arousal. So these can manifest physically, like heart rate. Again, these are racing thoughts, hot, sweaty palms, sweaty armpits, generally hot, quick breathing, shallow breathing. These are all symptoms of panic attacks. And then again, it reaches its peak in a matter of moments and subsides within minutes as well. And for a proportion of these individuals, the panic attack may be preceded by a cardiorespiratory instability. So agoraphobia, the screening question here, sorry, that's a big yawn, is, are there many things you're afraid to do and many places you're afraid to go? So agoraphobia is characterized by fear or avoidance of multiple situations due to thoughts that escape might be difficult or help might not be available in the event of developing panic-like symptoms. So in order to meet criteria for agoraphobia, this diagnosis requires endorsement of symptoms occurring in at least 2 of the following 5 situations. So using public transportation such as automobiles, buses, trains, ships, or planes, being in open spaces such as parking lots, marketplaces, or bridges, being in enclosed spaces like shops, theaters, or cinemas, standing in line or being in a crowd, or being outside of the home alone. So 2 of those 5. In 2/3 of all cases of agoraphobia, initial onset is before age 35. And there is substantial incidence risk in late adolescence or early adulthood, with indications for a second high incidence risk for people over 40 years old. So there's kind of like peaks in its prevalence within the population. Negative events in childhood and other stressful events like being attacked or mugged are associated with the onset of agoraphobia. Look how it says associated. It is not causal. We cannot make a direct link to it. Again, associated essentially means informed. So please look at this from a systemic lens. I really encourage you all to take causal language out of your vocabulary when you are speaking in general, and particularly when you are speaking professionally. Also, individuals with agoraphobia describe the family climate and child rearing behavior as characterized by reduced warmth and increased overprotection. So again, when people have been asked about it, these are characteristics that have been noted. That does not mean that if you come from a family that maybe, again, however warmth is defined, that it is, you are given less of that, or shown less of that, and then overprotection, whatever the appropriate amount of protection is, and going over that. So again, just looking at these kind of valued and culturally bound labels of behavior here. Heritability is 61%, so there is thought to be a genetic component to this. The majority of individuals also meet other criteria for other mental health disorders. The most frequent additional diagnosis is anxiety disorders like specific phobias, panic disorder, social anxiety disorder, and then depressive disorders like MDD, PTSD, and alcohol use disorder. So apparently, of all of the substances, alcohol is the one that is most commonly associated with agoraphobia, though, again, it's just an association. So generalized anxiety disorder, this is usually labeled GAD. That's how we usually talk about it. So the screening question here is, are you a worrywart, unnecessarily anxious all the time about a lot of different things? So again, as we know, worrywart probably isn't known to everybody. So feel free to adapt that to make sense to your clients. So generalized anxiety disorder is characterized by excessive anxiety and worry lasting at least 6 months. Adults with GAD often worry about everyday routine life circumstances like a possible job responsibility, health and finances, the health of family members, misfortune of their children, or minor matters like doing household chores or being late for appointments. So these everyday kind of life obligations, things create quite a bit of worry and preoccupation in an individual who has GAD. So children with GAD tend to worry excessively about their competence or quality of their performance. During the course of this disorder, the focus of worry may shift from one concern to another, so it's not static. So differentiating this also from non-pathological anxiety, I think particularly because anxiety is becoming such a part of our, general rhetoric, it's important to differentiate, this diagnosis that can be quite debilitating from just, kind of life anxiety that happens in the course of being a human. So differentiating from non-pathological anxiety is the worries associated with GAD are excessive and typically interfere significantly with psychosocial functioning, whereas the worries of everyday life are not excessive and are perceived as more manageable and may be put off when more pressing matters arise. So with like kind of non-pathological anxiety, these are anxieties that are kind of able to be bracketed, kind of pushed to the side to attend to matters that seem more pressing. The ability to like differentiate or discern between those two aren't there in GAD. So the worries associated with general anxiety disorder are more pervasive, pronounced, and distressing, having longer duration and frequency occur without precipitants. So again, that may not have a origin, it may not have a seeming trigger, but it's just there. Everyday worries are much less likely to be accompanied by physical symptoms. So with GAD, those physical symptoms like heart racing, sweaty palms, shallow breathing, increased, breathing, those are not really accompanied, those aren't really present with non-pathological anxiety.